like most of our channels. There you go. I just want to let you know we're recording the meeting. And what the agenda for today is, actually what a little bit of housekeeping first, is, as I said, try to mute your phone. If you want to hear from you, and we definitely want to hear from you, please either write in the chat box or raise your hand. A little icon will come up, and or just break into the conversation. This is the kind of we're trying to keep it as conversational as we can, as difficult as that is to do in this environment. But feel free to jump in and just join the conversation. We are recording it, and the recording will be posted to the hub, which you can see the URL within a day or so, and along with the PowerPoints, and you'll find all of the other ones on here as well that we've been doing over the last couple of months. So it's quite a compendium of materials. And for those of you who may be new to the call, and we'll get to you in just a second, you are able to binge watch all weekend the prior ones if you missed them. So if you get inspired, feel free to do that. With that, we're going to just talk about the agenda for a bit. It's a very simple agenda. We're going to do some new participant introductions. We have a tradition here of just welcoming new people to the call so they can introduce themselves, say who they are, kind of where they come from. And then I'll spend one slide talking about the National Interoperability Collaborative. And then we'll move right into the discussion presentation with Jocelyn about the Da Vinci project. I'm particularly excited about that today because of the obviously the interoperability aspects of it as we look across the work we've been doing for a while now. So I'm really looking forward to getting to that. But it really is nice to hear who else is on the phone. We have a lot of returning guests and participants, but we also have a bunch of new people here as well. So the way we've figured out how to do this is for people who are new or who haven't been on a while, in the chat box, just write your name. Just type in your name, and I will call your name, and you get to say who you are, kind of what you're doing, pretty quickly because we've got a lot of people on the phone here, but we do want to introduce people. So welcome, great, people jumping in right away. So Wendy Umbrack, why don't we start with you?
Good afternoon. I'm Wendy Umbriak, and I work for the Michigan Health Information Network. And as many of you may know, the Michigan Health Information Network is part of the HL7 Partnership for Da Vinci, and that is one of the projects I'm working on. Thank you.
Thank you, Wendy. Terrific. Tim Rolfe.
Hi, Tim Rolfe, Washington, D.C. I run www.hospital-forms.com. We are the world's largest public repository of hospital forms, and we've got about 10 years of experience building software and clinical systems for clients in the East Coast, including two of the three best hospitals in the world, Johns Hopkins and Cleveland Clinic.
Excellent. Welcome. Lindsay Hogel.
Hi, can you hear me?
Yes.
Hi, my name is Lindsay Hogel. I work for Iris Health Solutions out of Alexandria as a senior health IT subject matter expert. My background is in clinical and basically have been at HL7 and worked in the standards arena for about 8 or 9 years, mostly in the area of nutrition, but now I'm focused on care plans and fire. Thank you.
That is terrific. Thank you. Amber.
Good afternoon. My name is Amber Weeks. I am a synthetic data product owner at the Michigan Health Information Network family of companies, including our Interoperability Institute.
That's terrific. I love the way you guys have termed that, the synthetic data purveyors. So that's terrific. Frank Hone.
Yes. Hey, good afternoon. Frank Hone. I am in product development, product management at Veradigm. Veradigm is a unit of Allscripts. We are active with Da Vinci Group, and our goal is to service our health plan partners and promote interoperability between health plans and providers for bidirectional messaging and clinical data exchange.
Fantastic. Fantastic. Thank you. Doug Bach.
Hi there, this is Doug Bach. I'm in Denver, Colorado, and we're working on a project between health systems and doing social determinants of health coordination of care with community-based organizations. So we're using HL7, so we're interested to hear more about the FIRE HL7.
Oh, that's great. That will come into a conversation, I have no doubt. Latif.
Hi, this is Latif Khalid from JBS International. That is a subsidiary of Blue Cross Blue Shield of South Carolina, and interested in the Da Vinci project and see how we can benefit from it.
Welcome. Lynn Richards.
Hi, Lynn Richards, based in Cincinnati, Ohio. A functional implementation software consultant for RSM, focused on within our public sector practice, focused on agency, health and human services, case management solutions for agencies, and just trying to continuing to educate myself in the space.
Oh, wonderful. Great. And Kate Cordell.
Yes, hi, I'm Kate Cordell from Sacramento, California, and I think I could just say almost exactly what, the same thing in the health and human services space, trying to link together behavioral health and social welfare.
Excellent. Great. Perfect topic for today's conversation as well. Dave Bergman.
Hi, this is David Bergman. I'm out here in Stanford, California. And I work closely with Christina Bethel at Johns Hopkins, and we've developed a set of tools to really engage families in well child care and health promotion. One of our key issues has been integrating with electronic health records, hence our interest in the topic today.
Oh, fantastic. Great. And let's see, Steve and Craig.
Yeah. Yeah, hi, this is Steve Ruth, and I'm here with two of my colleagues, Craig and John from SMC Partners in Connecticut, and we're working on a bunch of interoperability projects in Connecticut, Massachusetts, and New York, both in health plans, ACO environments, and in the social services world.
Right. Hey, I think now that I remember, we met at our New England event, I think.
We did, yes.
That's right. A familiar name. That's great. Thanks.
Thanks.
Under your name is John DeStefano.
Yep, he's here with us as well.
Okay. Hey, John. Welcome.
Hi. Thank you.
Hello. Welcome, welcome. And then Al Taylor?
Yeah, I'm Al Taylor. I'm a clinical informaticist in the Office of Technology at ONC. I'm the technical lead for social determinants of health, as well as the technical lead for our soon-to-be final U.S. CDI, U.S. Core Data for Interoperability.
Fantastic. There may be some folks who are not on the computer that couldn't put their name in. Is there anybody else that is would like to say hello that's not on the computer? Going once, going twice. Okay. Well, as we move forward, feel free to join us. I'm going to just one more pitch for those who are both on their phone and on the computer. If you want to change your phone number to your name, just hover over your phone icon, and you'll see an opportunity to change it to your name, so we can get you into the conversation here. Well, thanks. Welcome. It's great to see so many new people on the call here. It's a great opportunity to continue doing what we're doing around the National Interoperability Collaborative. And I wanted just to give you just a 2-minute overview for people who are new to this, perhaps. So the National Interoperability Collaborative is a couple of years old, although the website and the Collaboration Hub is just about a year old. Our purpose is best defined in terms of how we define ourselves as a community of networks. And we recognize and realize there are many networks out there, and we use the term networks pretty broadly. So we consider within the health domain or the human services domain or education or public safety or public health, these large domains. And within each of those domains, there are networks like the Karen Alliance, like Sequoia, like a whole variety of other ones. And our mission, our passion, our vision is to try to connect across those domains to facilitate conversations that are multi-domain. Obviously, there's a ton of work going on in each of the domains, but we think that there's a real value and some unique value in being able to cross those domains, especially as we address complicated conversations or complicated questions around multi-systemic involved people or families or children or adults, and how do we facilitate that communication across those domains. It's not an easy thing, of course, and that's in many ways the purpose of what it is and why we're here today. Off to the right side, you see a colorful picture. A couple of years ago, we dove into this topic where it became very clear for HIMSS and articulated this kind of core theory of change around 6 domains. Obviously, that's a simplification of the universe, but it's a way to get our arms around it. It's a way for us to think about it, and it's a way for us to begin to structure conversations so that we can have meaningful discussion and begin to standardize language, begin to understand each other, and begin to, in a sense, harmonize the various approaches to addressing the various topics that we all are involved with in many ways, has already been described by many of the people who've introduced themselves on the phone. I'm going to, I think I'm going to advance the screen. Sometimes it moves, sometimes it doesn't. The collaboration, I'm not going to go into the Collaboration Hub now. I would hope, or I would expect for those of you who are new to the call to join the Hub. There's no charge to join. It's a community. We're approaching 900 members now from all across the country and other parts of the world. There are various groups on the Hub. There are affinity groups, and there are lots of conversations happening, as well as many resources that are available. What we're trying to do is we're trying to create this virtual watering hole where people can not only post materials and access materials, but to actually facilitate the conversations across those domains and between sessions, so we begin to build on that. That's our vision. We will be talking more about that. We are continually looking for new people to join, become active members, and later after the presentation, assuming we have some time, we'll talk a little bit about the proof of concept we're developing, which is actually focused on implementing some of these concepts as well. And we're looking for people who want to join, participate, advise on that, as well as get more deeply involved in the Hub and in the NIC itself, and participate in the curation and the facilitation of these groups and of the knowledge and learning that's going on. So with that, I want to turn now to our presenter, because that's why many of you are here today. And I'm going to ask Jocelyn Keegan I'm going to actually stop sharing my screen. I'm going to ask Jocelyn to open up her screen. And you can see her bio here, deeply involved in the field of interoperability across, particularly within the healthcare field, and has been leading the Vinci project for a couple of years now. As we've been leading up to this conversation, it got us very excited about looking at and understanding better all the various moving parts in this space. And in particular, how do we connect the social and human services to this so that we can address social determinants more effectively and also fulfill the promise and the hope and the strategy of value-based care. And so with that, I'm going to turn it over to Jocelyn. I just want to remind folks that this is going to be interactive. She's going to ask questions, and you're going to also ask questions, and either by raising your hand or diving in at the appropriate moment. So let's see if we can hand this off seamlessly. I'm going to stop sharing, and Jocelyn, take it away. We've got it here. Voila. Technology at its finest.
It's awesome when it works out the way that you want it to. So first, Jocelyn Keegan, I work for Point of Care Partners, and I'm the program manager for Da Vinci, as Daniel mentioned. There is somebody in the background that's got a lot of static, so if you're not on mute and you think it might be you, if you can throw yourself on mute, that would be great. My fellow colleagues on the call that know me know that I can generally talk over anything, so so I will persevere. So I'd first like to say thank you for the folks from the National Interoperability Collaborative and Surge of Change for coming to find me. It's really fantastic to hear folks in the audience that are interested in hearing more about what we're doing with Da Vinci and the community that we're building in HL7 around fire in general. And it's humbling how many people already know the work that we're doing that haven't necessarily heard it from us directly from a program team. So I'm going to take us through a little bit of background on the project today because I see a lot of new names. I see some familiar names. I'm excited to hear my folks from Veradigm and Myhin out there in the audience. And talk a little about the project itself, sort of how we work, what our focus areas are with the implementation guide work building that we're doing, and ways that people can get engaged and involved. And I've had a good set of conversations with both Adam and Daniel about really not just talking only about what we're doing specifically for Da Vinci, but sort of what's the applicability of the model that we're using with these fire accelerator programs to actually bring together and build communities of folks around a particular domain, and really the power that we've seen and the success that we've been able to see and the way that we've been able to accelerate the work that we're doing. So I'm going to set the stage a little bit just about sort of how we got to where we are today. So about 2 years ago, I got invited into a conversation. HL7 used to run these meetings called Partners Interoperability, where they would do similar to what Daniel and company is doing here today, is bring together communities. And really the question was how could HL7 in this burgeoning fire standard help solve core business problems for those communities? And so I was attending those as a participant and raised my hand and volunteered to work on a particular use case around 30-day medication reconciliation. That was our first use case and where we sort of got born from. But the CEO from HL7, Chuck Jaffe, a gentleman from the Blue Cross Blue Shield Association, who many of you may know, Linnell James, through the Gravity Project, and a gentleman from CMS, Bob Dieterle, invited me into a conversation to really say, could payers and providers come together and essentially use the footprint that Argonaut had created of building standard-based APIs using FHIR to open up the data that's in the EHRs to help solve challenges for data exchange between payers and providers. And I would tell you, it really was an open question. I think HL7 at the time was really trying to figure out how to engage the payer community at HL7 and within FHIR, and sort of there was in the background sort of the continued movement towards change of moving people to value-based contracts through actions by CMS with MIPS and MACRA. And we were really, I think, situated almost a perfect storm for sort of these conversations to happen. And a number of the national payers that were involved at the early days and the EHRs really understood that if we were going to lay out and leverage FHIR as a way to solve these problems, that we really needed to do it in a coordinated way. Because what was happening right now is, and many of you understand this, especially in sort of the seat at the table that you've got in your own organizations, is that, if we do this as a one-off, even leveraging FHIR as a new standard, if we didn't come up with standard ways based on specific use cases to build guides for those specific APIs, that we would end up with a bunch of spaghetti out there in the market, and that we would just continue the challenges that we had around interoperability today. And everyone fully acknowledged that the way that this data that was being shared today was being done, via high-tech standards like the fax machine and custom files and Excel files and literally putting nurses in cars to go and download records from EHRs in the market, because that was the most effective way that providers and payers could exchange that data to meet the increasing demands of the value-based contracts that they had engaged in either through Medicare Advantage or increasingly commercial lines of business, and their work with the feds, with CMS, with Medicare in general. So there was an agreement, I would say, early on from a core group of about probably 10 or 15 organizations. And we spent the fall essentially talking about how could we do this? Would it work? What would the funding model be? What should governance look like? But everyone very quickly agreed with the premise that our goal would be not to implement, but to really sit down and figure out what are the core business problems that needed to be solved, what was the data that needed to be exchanged, the burden that needed to be reduced, and that FHIR was the way that we were going to be able to do that, and that we would do that by building standards-based APIs, implementation guides, essentially recipes to build common APIs that we would build reference implementations to basically allow people that were picking up the IGs to use them, to be able to test, to make sure they were compliant with what was in the implementation guide, followed the instructions, could bake the cake correctly, and that we would create the right tools, and we use the term playbook for anyone in the community to basically come and engage and start to use these assets. And I have to tell you, we were flabbergasted, I think, at the reception and the attention that we got as we started to move forward into the industry. I paused for a second to talk about the fact that everyone that was involved at the very beginning, and I think the people that continue to be involved, understand that we're going through a long-term transformation as we move from fee-for-service to value-based care. And my conversation that I have when I'm talking to technical audiences is generally, the onus is on us as folks that understand how to use technology to improve and to reduce the complexity of what we're asking provider and provider staffs to do, and for patients to have to navigate through the tools that we provide to those folks that are out in the caregivers in the community. Because right now we've essentially pulled apart administrative from care, so that sort of the X12 side of the house from what traditionally would be the EHR side of the house. And that as we shift to value-based care, the onus is on us as an industry to really produce the right tools and the right information for folks, whether they be in the primary care practice, at a specialist, out at behavioral health, or inside the payer organization, with the right information at the right time, so that you can do things prospectively to actually improve that patient's experience and the outcome for that patient, as opposed to what we do today, which is largely archival exercises that happen out of claims to exchange this data, or PDFs that get faxed over and then OCR'd by large data systems in a less than perfect way. So if you look—
Jocelyn?
Yeah, sure.
Let me just jump in here for a second. This is Daniel. To take a pause for a second. So as this community has come together, how much of it was driven by sort of a collective spirit, or was it driven by colleagues at ONC or CMS or the provider community or payer community? Well, can you describe a little bit of the formation of that? Because that seems to be a critical piece of the equation here.
And I think you're right. And I think it is about sort of the right folks at the right time. So there's a couple things that happened. So I think that there were early adopters of FHIR in the community. There were some of the large national payers that really understood that, I'll use an example. My steering committee, I'm going to say one thing. This is an exercise that takes a huge level of emotional intelligence. This is it's every single one of the participants in the project at the very beginning really was an 800-pound gorilla in their own markets. And there's a lot of personalities, and everybody's used to sort of in their market doing what they want to do, whether they're a payer or a provider or the government entity. So if you think about who we had at the table at the beginning, and I'm going to flip forward a little bit just so you guys can get an idea. We started with the 4 biggest EHRs at the table, actively participating in the discussions. We had, I think, 2 or 3 of the national payers at the table. So Humana, Cigna, United was there, the Blue Cross Blue Shield Association. We had some of the big hospital systems that were involved in some of the early conversations. Chuck Jaffe, who's the CEO at HL7, is a doctor by training and really has an amazing relationship with sort of those advancers. So we had John Hopkins at the table. We had some of the bigger hospitals that were actively engaged. And I would say we were sort of learning at the knees of some of the work that folks had done out in Utah. So I had spent some time with Stan Huff early on, really understanding sort of how to get sort of these communities get built. And there was a tremendous amount of goodwill. And it wasn't so much, so I'll compare it to Argonaut, where there had to be an answer for meaningful use of how data was going to get exposed by the EHRs. So they had to come up with a standard way to do it. There was a really great forcing function there, which often we require in this industry. Here, I think people could see sort of the coming train. More and more stuff was going at risk. MA is becoming a larger piece of business for a lot of the payer community, and everybody's drowning in more and more burden, right? Whether it's prior auth or clinical data exchange or medical record exchange or sort of just attestation around quality measures was really was growing. And the big guys, I think, said on the payer side, I could go and make everybody write to me directly, but that's not the right thing to do. So that's where I get back to the high emotional intelligence. There was intent that this was a place that there were no standards. We needed standards. Everyone acknowledged that standards needed to be created, and that no one person could really drive it, that it needed to be collaborative. And if you can think about it, it's at the same time too where the conversation is happening about not only how do you write data out of the EHR, but how can you get data into the EHR and workflow in the smart applications and the technology behind smart coming out of Boston Children's was starting to emerge. In the first week or two where we were forming, Apple announced that they had gotten the health kit out into the market. And a week after we sort of gotten, the 20 or so people that were shaking their heads saying, yeah, we think we can do this, JP Morgan and our friends at Berkshire Hathaway basically came out and announced that they were getting into healthcare. And so all of a sudden you had execs at all these organizations saying, if they didn't already know the word, what is FHIR and what are we doing with FHIR? And so that gave us sort of, I would say, the wind at our back to make forward progress and get people to sort of lean forward and say, yeah, we can do this. But and I'll actually pick on Frank a little bit because he's on my operating committee for Da Vinci. Sort of the environment that we operate in is it's really rare, I think, to work in an industry like ours where I have competitors on calls and in meetings and at connect-a-thons working side by side, trying to figure out what the right thing for the industry is doing. Frank, I don't know if you want to add a little bit of color from your seat, from the Allscripts paradigm seat. And
Frank, you may need to unmute yourself. Or where are you?
And I would tell you, we'll see if
muted, double muted. So from a collaborative perspective, we're an EHR, part of an EHR, so we do sit with Cerner and Epic, and there is not a sense of real competitive tension at all when we're developing and talking through opportunities. Similarly, health plans who compete heavily in the marketplace are also, quite collaborative. I think there's a vision for creating something better for everyone that sort of transcends the natural market competitiveness.
And to the point around sort of the government aspect of it, so as part of my steering committee, I actually have representation from HL7. Chuck actually sits on my steering committee, and we have somebody from CMS, and CMS has actually funded a number of our early use cases around the prior auth space and really getting better quality information into workflow for provider teams about a patient's benefit. And I talk a lot when we talk about that prospective piece of when we rolled out HIPAA, we made prior auth an administrative transaction, but at its core, it's so based on clinical data and clinical activity that one of the things that value-based care is going to do is really going to force those two worlds to come back together, because what your benefits are inherently affect what your care options are, and what you and your provider decide as a patient is your best course of action. And so making that information transparent to a provider is critical. And CMS has been an amazing partner with their work through MITRE, funding of MITRE, to actually get those early implementation guides built and the early reference implementations in place, and supported us through, connect-a-thon after connect-a-thon around that work.
So can I just say, is it too simplifying to say that you guys came together around a particular use case early on that everybody could get their arms around?
I would say we came together around the concept of value-based care, and the concept that clinical data needed to flow between payers and providers, and that in between that, the early members really understood that the paradigm between payers and providers is changing. And I'll caveat that statement by saying, not everyone at every payer and every provider involved has gotten to that paradigm shift, but that really the way that as people move into contracts where, if people aren't familiar with the concept of value-based care, it's essentially putting risk and reward in the model between the payer and the provider, that the more you focus on certain known, clinical objectives and best practices, then rewards and higher payment is given to the provider for that care. And so once you're in that at-risk model, the relationship, historically between payers and providers would be more fraught, I think, and that value-based care really shifts the paradigm between those two into a more trust-based relationship, and using things like prior auth that would have seemed restrictive in the past transform into more tool-based tools to help that provider now manage their patient population. that's a really simplistic statement that would probably create some distress for people if they heard me say it. From a patient perspective, there's a lot packed into that, but we're on a path of really looking at sort of how we manage that population of health between a payer and a provider. I would say is changing fundamentally, and everyone in the industry, not one organization versus another, but portions of these organizations are literally doing mass experimentation out in the market between each other to figure out what models really work and are going to be sustainable moving forward. And so I think that all the people on the screen I would put into the category of early adopters, the people that are sort of leading, and behind them, there's now regulatory pressure that we're seeing coming out through NPRMs from ONC and CMS to really move towards more aggressively these models. And there's a little bit of a yin and a yang there, right? About as we actually develop implementation guides that could become standards, then that gives CMS or ONC tools to be able to point to, just like Argonaut has done with ONC on the Fire API front.
Great. So I'm gonna hold off on my question, which is how do we bring in all of the other parts in addition to the clinical part? I know that people are thinking about that, and we'll come back to that in a bit, because what you've described in terms of this coming together, really a forcing function with value-based payment, I think that there's an obvious question out here, which was all of the non-clinical questions that come up that we talk about, and many people talk about, is how do you get those into the conversation as well, because they're not necessarily in the same payer-provider community. Many of them are from the government side, either state or local government or federal government. So we'll come back to that, but this is fascinating. So why don't you give us a little more background and just take it away.
Sure, and this is just, I'm gonna not speak to this in detail, but just to give you guys an idea of sort of where we've been and where we're headed. In 2019, we started the year, I think we had, probably 9 or 12 use cases starting the year, and then these NPRMs dropped from the feds. And so we said, oh, there's more work for us to do here because there's no standards for a lot of the things they're talking about. So we actually expanded the number of use cases. We were able to do that because more folks sort of were finding us and wanting to get involved in the project. And we started to create partnerships with groups like HIMSS and NCQA to really figure out how do we get the right experts. And if I think about sort of the applicability of sort of the, how does this work beyond sort of this value-based care community that we're working on from a Da Vinci perspective, I think that this model of bringing together really the best and brightest from the different organizations. We have the SMEs that live with these problems on a day-to-day basis, the product managers, the folks from the operational roles inside of these organizations coming and spending time on weekly calls to try and figure out, first, what's the business problem you're actually trying to fix? And how do you do that and express it in a way that can be automated using technology? And how do we pick up this new technology and find the people that know the most about this new technology, the smartest people that know fire, and overlay them with folks like me that herd cats for a living and understand the domain enough to be able to take sort of this I would say like A team on each of these individual topics to progress the work forward. It's a really powerful model. And I would tell you candidly, I think we are all gobsmacked at the amount of success and the amount of speed at which we've been able to do this. But it's that adage of anyone who does this sort of convening work is you put smart people in a room together and everybody is aligned correctly, you can get amazing things done. And we're really seeing that in the outputs. It's really the smartest people that know this content the best, that really understand the business challenges. And from that, we basically create the guidance around what the project is. Then we build the implementation guide, the reference implementation, and we get people to go to Connectathons and test it. And we build testing strategies into it. We actually have a company, Aegis, that does all of the testing work for us to make sure that we're eating our dog food first, and that Connectathon and the calls go public once we figured out what the problem is we're trying to solve with each of these implementation guides. So anyone in the community, whether you're in a payer or a provider, you work in a governmental agency, you're out at the farthest reaches of the different care teams that are involved, the calls are public and anybody can get in and participate and speak up and have input into what goes into those implementation guides.
So did you find that people are stepping up to lead those various pieces of it? How much of that how much cat herding did you have to do to get it started? And then you gave everybody a little catnip, and they had their people following them.
You know, I think that I'll say candidly, I've worked really hard from a PM perspective to not make people out and out vote against each other. My priority is more important than your priority. One of the things that eased our pain on that was that we grew the membership from about 20 members to now we're up over 40 members. So that brought more dollars in to be able to hire more folks, right? I started, I think, with 10 to 15 hours a week on DaVinci. I now spend half my time on DaVinci. One of my NCPDP friends is on the call, and she knows that I had to like beg off of some of my NCPDP work because it's a hungry volcano. You know, we could add twice as many people to the project and still it would absorb it because of the type of work it is. I would say we've created a pattern in how we work, and I've got a slide that speaks to it a little bit further in, Daniel, that, you know, we do that work around sort of what's the business problem. That helps us suss out who in the market, who's coming to the calls, who wants to raise their hand. And we tend to have sort of 3 leads on a project. We have somebody from a payer, somebody from a provider, and then we may have a paid staff member, depending on the complexity of a topic. So I'll use risk-based member identification. Cambia Health is one of our members. They're amazing. Their CTO is a former CISO. He's an early investor in FHIR. And they wanted to get that use case started well before we were going to start it. So they actually volunteered to hire the staff themselves and fund the use case. What that use case does is it basically says between 2 trading partners, this is the list of people we agree are in that risk-based contract that we're talking about, so that you have permission to pull the data on that particular user. They're ready to go to production before everybody else is, just because of where they are in their journey. And so that ability to do that in an automated way versus an offline file or through a more manual process was critically important for them to get it done. And with them came the 2 hospital systems they're working with. And so my leads on that are one of my staff members who works for Point of Care Partners is a lead on the project. She sort of plays the project management role and sort of overall leadership. And then the SME from the payer, the Cambia hired person, and then somebody from the provider organization that's actually implementing this first. And then the call happens publicly. So there are active members. There's probably a core group of, I would say, probably 5 to 20 people on a weekly basis that come to meetings that happen once or twice a week on this particular topic. So some of the folks go to two meetings. There's sort of this small core group of about 8 to 10 people. And then there's a public call that can have anywhere from 20 to sometimes 60, depending on where it is in the process, to actually review the actual writing of the implementation guide itself. It's pretty crazy.
And then after that gets done, that sort of disappears, or people come back and they join other groups, or it's kind of like a disappearing task force in a way?
It's what I would tell you is I think it's about where people's interests lie. And I'm going to take you to a picture that I think sort of lays this out. So here's all the implementation guides. The HL7 process itself is iterative, and it's really one of the powerful things around how these implementation guides are being built on the FHIR side is essentially you get a draft standard out, that STU1, that goes through a process at HL7. And then in between each of these activities, there's an expectation that this IG has been to a number of connectathons where people come with both sides, right, of each side of the API and exercise it, figure out what's wrong with it, get feedback into it. And that cycle happens, it's, I would say, probably about a year-long cycle, maybe a little less, maybe a little bit more, to get through to the concept of getting through a ballot process and then going to publish. We actually chose not to go fully to publish to a few and just to move straight to the STU2 process for some of our guides. So this gives you an idea of this bolus of work that's happening. There's sort of a natural grouping of subject matters that these IGs have sort of fallen into. The individual use cases, sort of, it's like an order of operation. Like we did quality exchange for data measures, which is a framework that allows basically anybody to define how to express the completion of a measure or the data that's required to show that you completed a measure as a FHIR, in FHIR. And then we now want people to say, well, now I know you're missing something. So this gap in care is now telling somebody, hey, I'm missing a data point. And so we had to do the framework before we could do the, hey, you're missing something step. And so there's a community of people that are all attached to that as it moves through the maturity curve, if that makes sense.
Who blesses the implementation guide? I mean, at one point, because that's I think a relatively new term outside of your world in terms of the direction for it that is, just speak up for a minute for those people who want to understand that a little bit better.
So it's actually one of the big differences when I talked about how Da Vinci was different than how Argonaut worked. Argonaut basically created an implementation guide that was out in the market that anybody could pick up and use and sort of alter as they wanted. If you think about an implementation guide as a recipe, you know, think about you're in like a test kitchen, right? That's got every tool. How do you take the right tools and build the right recipe that's repeatable? We chose with Da Vinci, because of the participants, to bring it through the standards process. So we live as a project under HL7, and pretty much all of our IGs so far have gone through the HL7 process. HL7 is an ANSI accredited organization, which means that things are done through consensus. And so we basically attach each IG to a work group at HL7, and that work group leadership works with our team members in the community around that work group to basically make sure that that implementation guide is up to snuff before it moves it into the balloting process. And there's a very mature process at HL7 for how that works. And I would tell you, we've challenged that in some ways and come up with some new paradigms to how to make that move faster, because we brought so many IGs so quickly into HL7, because it's all human powered. HL7's, you know, a volunteer led organization.
Okay, great, thank you.
Does that work?
Yep.
Okay.
Yeah, no, I think that's a great model as other domains struggle with trying to come around the table, you know, get into the test kitchen, figure out what we're going to be baking, and then no less come out with a common recipe. That metaphor works really nicely. And I think that in other areas that is a struggle for people to come to the table and to recognize that that's the end goal. It's not always as clear.
And I think that, you know, we've had tremendous support both from ONC and from CMS and the work that we're doing, and a lot of openness and feedback, I think, from the core ONC team as we've been moving forward in the process. Dr. Rucker's been a great supporter of the project. I mean, it definitely helped us that, you know, we had CMS and Dr. Rucker up on stage using the term Da Vinci regularly as an example of sort of the power of FHIR. That definitely worked to our advantage. I'll take a minute to talk a little bit. So when I mentioned earlier, we had all these disparate use cases. What we found was, as we actually started to digest them and work on them, was that there really were sort of some commonalities around who the primary user of that use case was going to be, but also acknowledge that the core group that was building the IG wasn't going to be the only group that ever used it. So like the member identification use case I was just talking about with process improvement that we've started, it's very clear now that we're 3-4 months into this project that this idea of giving people a way to negotiate which members you're actually talking about between two trading partners holds great appeal well beyond people that are doing value-based contracting. And so that's something that community is growing, and we're pulling more and more people into that discussion to figure out what does version 1 of that look like? And then what are the things that are out of scope that we'll tackle in version 2 and version 3? And then there are other things like when we first started to write our implementation guides around quality improvement, we literally presented an IG on 30-day medication reconciliation, and the work group at HL7 said, no, that's way too specific. We need something that is going to be a container for all of the different quality measures. And that really changed sort of the complexity of that initial IG, but made it something that we're now just adding additional quality measures. And NCQA, some of the groups, some CMS that were also doing some conversion of quality measures into FHIR, and other communities have now found us so that we can accelerate. We've now created a community around people that really are working towards completely transforming the way that FHIR measures are discussed and discovered and described using FHIR as the core tool.
So let me just pause for a second. I want to interject one complexifying issue. One of the things that we have addressed in multiple conversations earlier in the year were also some of the other standards. Not that we need to get into that right now, but I think within the health world, HL7 and FHIR are certainly the dominant, you know, that's the train has left the station there. When we start to look at education, or we start to look at public health, or even human services, we run into other standards. So I want to just put a pin in it for a second, because the process, which sounds like a brilliantly sort of designed and scoped way of addressing these implementation guides and the reference implementations, works within one standard. If everybody's singing off the same proverbial hymnal, one of the big questions that's come up, and again, I don't want to interrupt the presentation too much here, is what happens when there are other standards that other organizations are using or other providers of information are used to using? How do we then integrate that, or how do we conceptualize that as we go forward? And I don't know if that's come out at all in the work that you guys have been doing at all.
Yes, it definitely has, and I think that there's a couple things. I think that FHIR is a relatively new standard in the industry compared to other standards. I think that there are standards out there that are currently the named way to get work done. So prior auth is one of the places. The naming of our prior auth workflows actually are very distinct and discrete and not called prior authorization, because we're really talking about what do you do upstream of a prior auth, because X12 exists and they are the law of the land of how a prior auth gets transmitted between a payer and a provider today. I've actually worked very closely with some of my colleagues over on the NCPDP front, who does all the pharmacy-based standards, because we're doing some very lightweight things around pharmacy that payers are going to be mandated to do for CMS, for their qualified health plans, and some of the smaller the lines of business that are managed under CMS control, to show that it's something different and not replacing. You know, we have a lot of sunk investment in existing standards, and we have a lot of success. So like when we do our prior auth work, we very clearly delineated that we're doing prior auth work on things that are a medical benefit, because there's a lot of maturity out there in the market around what's happened at NCPDP with electronic prior authorization and work emerging around real-time benefit checks and formulary and benefit. You know, there's a decade, 2 decades of investment, you know, around that work, and we don't want to we want to honor that. I think people often sort of that don't understand those other domains as well can oversimplify sort of the significance of that investment. But I think that we've got the variety of experience and sort of the cacophony of voices that we bring together in the model allows us to not plow over things that are, you know, significant investments for the existing participants in the market. And I view FHIR as in some ways solving problems to where the standards don't exist, but also a way to sew together existing gaps between standards organizations in that ability to get the data out of the EHR in a meaningful way and to get content back into the EHR, since that's the primary home that most providers are using today to conduct their work.
Right. So it raises, there's a little bit of chatter on the site here around that, because I know that one of the things we're talking about are, you know, education standards. So if there's an exchange of information between practitioners and schools or school-based nurses, that's one thing, or other edge cases like with public safety or police in terms of arrests or diversion programs. How does that information get in? Opioids, overdoses, how does that get into, you know, the records of those kinds of programs? And of course, there's the National Information Exchange model that many human services or some human services programs and public safety are using. So it's interesting, and we'll get into this a bit hopefully, is, you know, is that harmonization or that reconciliation between some of these kinds of different standards. And I'm wondering if HL7 accommodates that broader conversation, or if there's another body, or if that's kind of an ad hoc pickup in terms of really aligning those different standards as critical information, especially around value-based care and different populations, comes to the forefront. How are those things going to be addressed? And again, it may not be the exact right moment to address that, but I do want to put it on the table as we go forward.
Yeah, I think it's a great point, and I'd love to hear if anybody has any thoughts from the audience, but I think that there are some constructs that already exist inside of the healthcare domain today with groups like NCVHS and WEDI to really help the coordination within healthcare IT. I actually, in my personal life, am involved in my local politics, so understand some of the challenges you're talking about around data exchange. To me, I think one of the positives about FHIR is that it is a modern API-based standard that allows people to pick up just the right amount of information at the right point in time to be able to get it to those disparate points. I listened to one of my payer colleagues who was a very, I would say, late to the game sort of, FHIR is the latest, fancy, shiny object, and I don't really think it's going to help. And he works for a small Blue that's based in the South that does a lot of their own technology. They're a really lean shop, and And I watched him go through a transformation where he said, hey, y'all, all those things you could never do because it was going to cost too much money and you'd never be able to get approval for the spend, you can now do just at the efficiency of moving to a modern technology architecture and being able to hire people off the street that could write fire versus someone that needed 10 years of EDI expertise and that every transaction was the entire kitchen sink, right? That you had to deal with everything. It allows you to be very discreet. So I think that's powerful as we start talking about how to sew together all these disparate technologies. But what I see from where I sit is, and I think I've got a little bit of a unique situation where I sit in the industry right now because I'm in between pharmacy and the medical side, is that it's the ability of a particular community that has particular problems they want to solve to come together and to pick the right solutions for that community. And it's going to be a little bit of this and a little bit of that. And we're going to choose to do this or this and give some flexibility to where the people are in that community in reality. And we talked about this a little bit offline, but you know, what you can do for a behavioral health specialist that doesn't have an EHR, that does all their own self-billing, is way different of a solution that when you're going to offer to a surgeon that works inside of a hospital that has, you know, 3,000 beds and 20 locations across the country, right? And so that idea of being empowered to free data to flow, so then to build the right outputs to meet people where they are in reality, I think is the power of what we're talking about, the sort of curve we're coming up to in the road, that we can now actually start to get just the right data out, and then transport becomes separate than the actual freeing of the information itself, if that makes sense.
Yeah, let me even take a risk here for a second, because this is stuff that's been coming up. I don't know if any of the folks on the call have a specific question or statement they want to make around this. And then I do want to turn to how all of these other pieces that come together, as we talked about earlier. I just want to open up the floor to see if anyone wants to sort of chime in at the moment on this standards conversation.
Nope, no one?
Okay.
Nope. Excuse me, hello?
Yes.
Yes.
My name is Anna Arlova, and thank you so much for the wonderful presentation. Right now I'm looking at this implementation guide status, but I actually have a question about a real adoption of these standards. You just have them mostly in standards for trial use, and the first one went through 5 connectathons. But how many of them were actually adopted, or this is just still standards for consideration to use?
I actually think that's a great question. So I would tell you, again, sort of this reference of like, we're coming up a road and we're about to take a turn and seeing things working in reality. Again, because I'm the program manager, I get to talk to folks. So there's a couple of our members that have announced production plans with the IGs that we've developed. People are using FHIR in production on the consumer side of the business. The EHRs and folks like Apple have been using FHIR in production for a year, a couple of years now, depending on sort of the version that they're using. We started our work about, in earnest, I would say probably about 20 months ago, building these implementation guides. And that I see sort of from my seat, there's a grouping of communities that are coming out with production ready or actual production versions of these early, the ones that have been to 4 and 5 connectathons, and some of the ones that are 2 or 3 connectathons. I would expect from the membership and the community, not just people that are members of Da Vinci, but people in the greater community, are now actually starting to get to a point where they're rolling out their initial versions of product or point-to-point solutions using these implementation guides. One of the factors that we deal with all of this is who is going to be on either side of the API. And so a number of, I would say, the hospital systems and the multi-specialty practices that are probably likely to be early adopters make a decision of whether they're going to do this themselves, whether they're EHR or their population health platform is going to be the API that interacts with the payer for these use cases or one of their vendors in between. And so we're really talking about sort of people, where this is in people's pipelines from a product perspective. And so from a program team, we've spent sort of 2018 and 2019 in build mode and starting to create the tools for our implementation users. And we see 2019 or 2020 really is that curve to people actually doing implementations out in the market. I don't know if the Myhin or the or my friend from Allscripts wants to talk about that, or if there are other folks on the phone that have been participating out in the community around sort of where you guys are in reality, not just with FHIR, but with your Da Vinci work itself.
Yeah, Jocelyn, it's Frank. I can add some thoughts to that. I agree with the idea that it's, 18 and 19 have been sort of a build and technical connection architecture emphasis. But from a business standpoint, we're about to go to production with one use case, and we're seeing tremendous interest from health plans who are now budgeted for use cases, looking at RFIs and wanting to go to market in 2020. So I think the industry is going to have a very active year coming up.
I'm going to take a second here. I'm just going to unmute folks. I'm not sure if everybody can speak here. I'm just going to go on unmute for everybody. And if anyone else has a question, and then I'll put everybody back on mute a second. And so if anyone else has a question, now would be a good time to raise the point. And of course, you can always add your questions or comments in the chat box. Okay, I think we're. Wait a second. Okay, I think we're good. I'm going to put everyone back on mute, and then I'm going to unmute you, Jocelyn, or unless you can unmute yourself there. Mute all.
Yes. I'm back. Can you hear me? And I think you may be muted as well, Daniel, if you're not answering me.
Yes, I'm unmuted. Go ahead.
Okay, good. So, so to follow up on that question, I think it's a great question about sort of where we are in reality. I'm going to talk a little bit about timelines, and I'm just mindful of how much time we've got, and I want to make sure that there's time for active discussion at the end. So we spent, as I talked about, 2019 really focused on getting implementation guides in process to be validated, going to connect-a-thons and making sure that these things were ready for prime time, making sure that our testing scripts and that the reference implementations worked. And we're actually going into a run-up. If you've got folks in your organizations that have been following along, we actually have a connect-a-thon next week in Philadelphia. It's a Da Vinci focused connect-a-thon. IBC is hosting an Independence Blue Cross. Our members have been really gracious in giving us free space to do connect-a-thons. And that's public. Anybody can come and attend. And then CMS is actually hosting a public connect-a-thon as well. We're doing that a little bit because HL7 is going to Sydney for their out-of-country meeting. They do one out-of-country meeting, one international meeting every year. And so we acknowledge that most people wouldn't get permission to go to Sydney. So we're trying to support folks that way. Although all of us, I think, would be more than happy to convince people to send us to Sydney. And then I'm just going to flip ahead here. And this is what 2020 is starting to shape up as I mentioned, we're really focused on really bringing the existing IG sort of across the line to that second level of maturity from a draft standard. And I would guess we're going to maybe add as few as 3 new use cases or iterations of our existing use cases in this year, really not looking to add anything new to balloting till September or January of next year, and loading the year up with connect-a-thon so people can come work together. We can really beat these IGs up and make sure that they're ready for prime time. And as Frank referenced, what we're seeing is, I do this analogy around, and I'm sorry if it's a horribly US-based analogy, around one of these implementation guides is like, it going live is like a game of Clue. You need to know like which payer with which provider, with which EHR, with which use case. And those need to match up, not just from a technology perspective, but from a contract perspective, like who's at that place in their business relationship that they are agreeing to share this data, which they typically haven't shared. And that business process work is actually much more sort of high level and complex than the actual writing of the implementation guides. And so what I'm seeing is my folks that started those conversations with their key partners a year ago, 2 years ago, are now getting to the point where it's contract renewals. They're now deciding to do this project. To Frank's point, they've now got budget actually built in, so that we see what I would say like hotspots happening. You know, the folks around Cambia in the Northwest, California's got a lot of activity going on. There's some folks in Florida that are doing some really interesting work. Some of our national guys are working with national partners. And so we're starting to see that footprint happening. But there's also, I would say, I'm going to flip back a little bit. There's a number of fire initiatives happening in the industry, and I just want to make sure we take a minute to look at that. So Da Vinci's one of these fire accelerators, really staying sort of core to our ideas of value-based care. Argonaut continues to take resource and time to build out some of the fundamental tools that fire infrastructure really needs. Karen is working alongside us, often with the same data, but using it for different purposes to get information to consumers themselves. And now, as we mentioned at the beginning of the call, and I think that Daniel referenced, there's a new accelerator, Gravity, which is solely based around building the value sets, the data that's needed to really talk about social determinants of health in a standards-based way. There's a new group emerging that's working on cancer research, and another group that's working on the pharmacy side, I think maybe clinical trials. I can't remember exactly what they're focused on, but there's now 6 or 7 of these accelerators out in the market working across different stakeholders to solve these problems. And ONC in the industry have been focused on this work at FAST, which, and I won't go into this in too much detail, but that there's basically tiger teams working with ONC to figure out what does the industry need to actually stand up, not, you know, point to point, maybe Frank between one of his trading partners, but anyone talking to anybody with all the right security and directory sort of support out there in the market, like our current clearinghouse and claims systems work that have been around for 20 or 30 years. So I want to pause for a minute, Daniel, and try and figure out sort of what we haven't talked about and what other people are more interested in sort of hearing about before we wrap up for today.
This is everybody's opportunity to ask questions, make statements. While people are putting their thoughts together, again, you can go into the chat box here. I'll unmute everybody in just a second. Where does Sequoia come into this conversation?
So it's interesting. One of the things that's great about this is we get to do sort of light touch points with the different members of these different industry projects. And so I actually get to talk to Dave Castle and Dee Dee over at Sequoia on a pretty regular basis. And if you think about a lot of what they're doing is establishing that trust framework. And I think care quality is another good place to show sort of, you know, the care quality team is trying to figure out how they could become the transport layer, right, for some of these use cases to flow against now that they've got these established endpoints out in the market that are talking to each other. And that really, I think the Sequoia folks are really trying to figure out how do we take, and they're working more at that ONC FAST level, how do we take all of the investment and the relationships and the domain knowledge and the agreements and leverage that for these emerging fire endpoints in the market. And I think those discussions are happening, like I said, at the ONC level, at this Tiger team level with FAST, and then across individual participants. And there's a ton of overlap just in the folks that are involved. One of my steering committee members, actually 3 of my initial steering committee members, all happen to also be Sequoia and Care Quality committee members. So there's a lot of the same people in these conversations, really trying to piece part out who's focused on what. And again, we do a ton of different analogies, but if you think about, you know, I think if I'm gonna abuse an analogy, we're the cars on the road. FAST is really looking at how does the highway actually get built, and the Sequoia, and moving into sort of the world of TEFCA, is really trying to figure out what are the rules of the road and how does everybody get through the toll gates and how do those all work. So.
Okay, so I just unmuted people, so let the chaos begin. Feel free to jump in here. I'm just going to be quiet for a second for people who find their voice or they're on mute. I think I unmuted.
The double unmute.
There. Yeah, there's a. So if you want to speak, you have to unmute your computer and your phone, I think.
I actually think if you unmute both, you get an echo.
Yeah.
But the chorus of people unmuting is not very loud yet.
Okay.
Hi, this is Rita Turks today, and I have a question for Jocelyn, because I was actually at the WEDI winter meeting, which you may be familiar with, because there were several presentations there that focused on a lot of these topics and crossovers, including FAST. You probably know Patrick Murda from Humana, and some others, and Lantana that's also, I think, doing perhaps some work with the IG development. And I'm actually involved also with the Tiger team that focuses on identity. And so perhaps I just, I just have a bias on some of these issues, but I was curious from your perspective and from what you've been doing on with the payer exchange world, what do you see as the biggest interoperability barriers in terms of everything that you're doing with these use cases, or what's being addressed like through FAST with interoperability gaps and fires, and how that plays into being able to advance what you're doing?
That's a great question. And I actually was, we kicked off a clinical advisory council that we've created Tuesday night. So I was down at WEDI and got to help Rick prep some of his slides for Lantana he included a bunch of Da Vinci content. And Patrick is fantastic. Patrick's one of my favorite participants. Sorry, Frank. On Da Vinci on a regular basis, because Humana is just like out ahead of the curve on he's just so bright, and they're just really executing really well. And I think that, I don't think that the barriers here are any different than any other interoperability barrier. If I talk specifically from a Da Vinci perspective and the things that are going to help us, are going to hurt us and lose momentum, there's this sort of love-hate relationship in the industry between regulation and innovation. And I see a push from the industry to allow advancers to innovate and to remove the ceiling on standards for folks so that people can go ahead of what the current sort of floor is of a standard. And so I think if we can continue to move in that direction, that will help us. I think people sort of grappling with and acknowledging some of the challenges, some of our existing standards, and owning that and coming up with clear paths to get exceptions. If you've got a better way to experiment doing something better, not that people don't have to support the current floor, but allowing people to innovate on top of it, I think is really important. So I think that there's that balance between, you're going to have your early advancers and then your fast followers. Things like privacy and security, we deal with between trading partners on a day-to-day basis right now. I think because it's new and because it's API based, right? So the data can flow more easily. I think that the rigor that organizations are looking at data exchange via these API relationships is going to be a barrier. But in reality, every single trading partner deals with this with existing either APIs or existing data exchange paradigms that they use today. So I think it's part of the change management that's the hard part. It's the immediate resistance. I do think that one of the things that maybe isn't a challenge, but I don't think that is maybe getting as much airtime, is when you look at the consumer directed effect around privacy and data security. There are definitely groups out there that are really pushing for consumers to be in control, so to almost remove some of the world of HIPAA that we currently live under. And I think that we haven't really had the kind of dialogue at the national level about that, like we probably should have. But I think the rest of it is just steps. It's how fast can we move? How many barriers can we remove? How can we execute against the work that you guys are doing on the Tiger teams to take those best practices and stand them up and empower them so that they can become standards, or at least known trod paths for people to get to success. So not everybody has to sort of fall down and learn as they go, like we typically do as an industry. But I don't see anything that is intrinsically stopping us from moving forward. I think that we're at a point in an industry, and maybe I'm biased because I spent the first half of my career in an industry outside of healthcare, but I think that we're at an opportunity where I think the industry can show that it can innovate and get to interoperability without being told it has to. And it's sort of the onus is on us to do that.
Other questions or comments? Dave, I think, Dave Walsh, if you're on the line, I don't know if you're muted or not. One of the things that, I'm sorry, is that Dave, are you there?
Yes, I'm here.
Oh, hey, Dave. One of the things that I'm sure is banging around in your head a little bit is as we think about, proof of concept with exchanging information with healthcare or with pharmacy for that matter, from the social and human services side, are there particular challenges or questions or things around the process, Jocelyn has just described, that you think are opportunities for us as we look at the industry, or are there any particular challenges that, as this, as our work begins to form here, that you'd be able to articulate?
Sure. Pardon me. Yeah, I think one of the focuses that we've had on this proof of concept work group that we're bringing up right now is to help educate people who could make use of the data that Jocelyn has been talking about and so forth. So it's kind of the opposite end of the activities that Jocelyn and others are working on, whereas she is building APIs into the data. The question then is, what value can you get out of this data, or aggregating the data, applying other technologies to it? So the proof of concept group that we've got starting up now is really looking at educating the community on how to use this data, and secondarily to build tools, and it is focused right now on open source tools that would allow the development of client-facing applications to be less onerous for people to be able to work on. So a couple of areas that we're focused on right now. The first steps in the work group were focused on person matching, and Rita, who is on the call, was certainly involved with that. And that's more prevalent, I would say, in the health and human services arena, where you're going to have many domains that you're exchanging data to or aggregating. So is the Jocelyn Keegan that you see in education the same Jocelyn Keegan that we see in healthcare? That's sort of a problem. So what we're doing right now is taking a look at the technologies that are out there for person matching, understanding that TEFCA has an eye on that too, but trying to educate our community on what the tools are that are available, and then secondarily, what is a framework that can be used and reduce the amount of effort that has to go into exchanging that data. Things like the smart interfaces and so forth, if they can be built into a framework, and again, I emphasize open source framework, so people don't have to get wrapped around the axle trying to understand from a client side how to do smart. A lot of that will be pre-baked on within the framework. So that's the goal, and the primary mission really is to educate people on the APIs that are available, educate people on how to use those, primarily education, but then as it advances, be an accelerator from the client side or a framework from the client side. So solving a business problem, people don't get wrapped around the axle too much in how do I do this little thing or how do I do that thing.
Daniel, if I can chime in there, I really love the way that Dave described that. And part of the philosophical, I think, discussions we've had within sort of this burgeoning fire community is, if you think about the building years, was really about fire and the resources and the infrastructure to make sure that it worked and that it would scale this new standard. I think that what we're in now is sort of like the period of the frameworks being developed and what are the implementation guides of the implementation guides, with this first pass of these communities sort of pouring in to create them. And then, you know, that is really the thing that will empower everybody to actually get to data transport at scale, because it won't be just one business partner talking to another business partner and using this common vocabulary. It'll be, I write it once and now I can reuse it with 5 or 6 different business partners. And if I have this adjacent use for the data and I only need a subset of that API, then I can custom build that API, or I can develop a standard for it for those adjacent uses of the information. And I think that paradigm is really powerful as we look at solving problems across, you know, where at the seams of these different domains that touch each other but aren't completely aligned.
That intersection is the, you know, is the question in many people's minds is, you know, when, you know, within the systems, within the health, the pharmacy systems, payer and providers, and it's fascinating to kind of listen to the progression, the evolution, the maturity of that, and the partnering that's going on there. I continually think about how else, you know, for those large EHRs, or the small ones for that matter, you know, when they're now trying to connect to the community providers who are, you know, talking about housing, food, nutrition, you know, transportation, those kinds of things, how is that standardized approach to accessing and exchanging that data? So when somebody leaves the clinical setting, you know, that continuity of care is not a separate system, right? And that's the question, and that is, you know, I think in a lot of people's minds. And when does that have to happen now? Does that happen after the highway's built and the rules are designed and the speed limits are designed and, you know, the lines are drawn on the highways? Or what point do you think that should be happening more? And I know Gravity is working on, you know, some specific you know, exchanges of information to address some of those things, at least from a payer perspective, right, or a billing perspective. Do you see or hear more of that's happening?
Well, and I think Gravity is more than just the payer perspective. It's really how do payers, providers, and other members of the community identify in a systemic way the patients, the people we're actually trying to care for, that need this additional support and needs additional services to ensure that we can get to that best outcome for that patient, right? Mm-hmm. And I'm not in the thick of Gravity, so I don't want to misspeak at all. But sure. I think I pulled up, this is an example of what we did last year. HIMSS has been a great forcing function for us to get people to make things real. So last year we took our 4 IGs that were sort of almost ready for prime time, were very draft. A couple had gone to ballot, most of them hadn't balloted yet. And we basically had a group, 16 of our members, come and demonstrate them. So every 2 hours we got up and people switched spots to show the same API worked for multiple vendors. Oh, wow. It was amazing. Yeah. And we were like 5 people deep for the entire 3 days of HIMSS at the Interoperability Showcase. So this year we're going to do the same thing, and we're going to do it for like 12 of the different interactions. And the reason I bring this point up is that interaction, if you look at the page that I've got pulled up right now, number 1 is literally out of the Argonaut spec. It's how do I actually schedule an appointment? And number 2 is somebody showed up at a cardiologist, and what can they get from that payer about that patient? Because the payer has a much broader picture than that cardiologist that's seeing a patient for a first time to get the record. They might also be able to get data via care quality, but what does the payer know about this patient? And you look at number 3, it's how do I stomp down or simplify the process to get an authorization done, right? Is the sort of, do I need to get an auth to do, to get this person sent home with O2, you know, what's the CPT code that's needed or the DIA code that's needed for that to happen? And number 4 is 30-day medication reconciliation. Every one of those really exemplifies a place today in healthcare where we drop to paper or we drop to a portal, right? And if you think about all the interactions that you're talking about in the space that you guys are working in, these are processes that are inherently manual by nature. And some of the things that are emerging out of this community are the tools to be able to put the right triggers in place, but you have to digitize the information in order for the trigger to actually happen. And you need to get it into the right workflow. If you trigger it inside the EHR and the care team member works for the payer, or the care team member works out in social services, you know, and never sees the trigger, then it's useless. So it's that idea of being able to have that asynchronous information and those triggers travel in that care team so that the right person that needs to see it can act upon it. And I would challenge the premise of, Frank, cover your ears, of the EHR being the owner of all of that information, because as we do a better job of interoperability, the home seat for many of the care team providers and the folks that are going to most be able to impact change, right, out in the community, like the pharmacist, like the care coordinator that might be in a community setting, like the behavioral health specialist, those folks aren't in that home EHR. So being able to get that data and that trigger and the link to pull the additional information to that person is what's really going to empower us. And coming up with a standard way to ship that clinical data back and forth, or that payer data back and forth, is just a foundational piece enable for us to get there. Does that make sense?
It sure does. The one thing that I would add is with these proof of concepts that we're starting up within the NIC, we're trying to make sure that that data will be available to as broad a population of people that should have access to it. For example, mobile applications for the patient and so forth, browser-based applications. One of our focuses is to make sure that that data can be aggregated and pushed out to even the patient themselves.
And that really gets back to a lot of the work that's happening at that FAST, ONC FAST level. And I know one of the women from the Identity Task Force spoke up, but there's real work showing the clear barriers and sort of what the best practices are that are out there. And my team, from a Point of Care Partners perspective, supports the ONC FAST team. They're looking to build that technical learning community around all of these topics. So I'll make sure that that we get somebody here to talk to this group about the work at FAST.
That's great.
Because I think that those are the macro level, right? It's not the technology that's the problem there. It's really the data use agreements and the permissioning and what's HIPAA and what's done out of out of a different federal branch, from a federal trade perspective, because it's a consumer application and not a healthcare application. Right. There's a lot of complexity in there, and it's our healthcare data that we're talking about. So creating those frameworks and patterns is incredibly important, and getting buy-in so that people will actually use them. Is step one.
So I want to thank you so much for sharing with us, just some of the incredible work that you guys are doing in the midst of this this storm of activity around interoperability. It's really been enlightening, and I'm sure there's lots of questions and lots of thoughts that are going to be sort of stimulated here. What I want to thank people who are stayed on the call with us here. We're going to shut down in just a second here. I want to just mention two things. First of all, I want to say thank you again for taking the time in the presentation. I know you've been traveling and busy and all sorts of things going on to share with our community, and I hope people have gotten a lot out of it. I know I have. I want to just reiterate, you heard from Dave Walsh before. He's leading, along with Rita and Eric John and a number of other folks, Noam Arts and some other folks, this proof of concept. So we're trying to get our boat running and looking at trying to demonstrate the exchanges of information, not only within our domains, but across and into a lot of the work that you're doing. So I hope that we will have opportunities in the not too distant future to do more of that, and maybe even sort of visit some of the connect-a-thons and start to get smarter about the processes that you're you're learning and adopting, because I think that many of them may be really applicable to what we want to do with you and do going into the future. And so you'll find people who are interested in the social and human services sector and the components of that, and as it relates to the proof of concept, you'll find more information about it on the hub at the Let's Get Technical group. There's a project there that is beginning to shape up, so please join us on there. Express your interest, reach out, email. You can message from the portal itself, and we'll be starting to really ramp that up and adopt some of the lessons learned. The last thing I'll say is next week, which will be our last. I don't know if you can hand me back the controls here. I might have lost it. So we have Chris Gibbons from. We'll be talking about smart cities next week. Chris is Greystone Group and also part of Johns Hopkins. And his approach at the community level is really fascinating, using technology and data to really create interoperability and address not only social determinants, but many of the questions around health equity and implicit bias. Again, linking together, bringing it down into the community at the community level. We presented a couple times with Chris, and he has a fantastic story to tell about this work. So that will be our last Friday call for the rest of the year next week, and then we'll start up again early in January. We're anticipating a series on social determinants and a number of other topics, and I sure hope we can get the ONC FAST folks on the call here and other suggestions that you would have for us. So with that, I want to just say thanks for everybody who's participating. We'll post the slides, join the conversation, ask questions, and hope to hear you and see you next week on the Let's Get Technical Friday calls. So with that, have a great weekend, everyone, and I'll signing us off here.
Thank you, Jocelyn.
Thank you.
Thank you, Daniel.
Thanks, everybody.
Thanks, Jocelyn. Thanks, everybody. Bye-bye.